Hello, everyone. This is Nicolo Bizzarri. I am the ENICO chair, and I have the huge honor and privilege today of being here with Professor David Cibula. Welcome.
Hi, Nicolo.
So we are at ESGO Congress 2024 in Barcelona, Spain, and this is an interview under the umbrella of ENIGO and International Journal of Cancer, where we want to make interviews about the very hot topics and highlights of this Congress. And I am sure that probably the best highlight of the Congress is the presentation of the results of the SENTIX trial, which was delivered yesterday by Professor Cibula. So today we are going to discuss about this. Thank you for being with us again.
And I am very pleased for that. Thank you.
So let's start with a few questions. The first question is, can you briefly report on the methodology and the survival results of the SENTIX trial?
Well, the SENTIX trial was single-arm, observational, prospective trial, international trial, which was conducted at 47 sites of 18 countries, mostly in Europe, but there were also 2 sites in Argentina and 1 site in South Africa. And patients who were eligible, which simply saying were early stage tumors up to 4 centimeters or up to 2 centimeters for fertility sparing, were referred for surgery. And intraoperatively, SLNs were sent for frozen section. It's important to point out those who were positive during the surgery or those who did not have bilateral sentinel lymph node detected were excluded. If negative, they continued in the study. Sentinels were processed by ultrastaging and then the follow-up.
That's really a great study. And the following question comes natural. Why at the beginning of all this history it was decided to design a single arm instead of 2 arms, potentially randomized trial?
Well, that's always to choose the right design is the key. Well, the story was that I've already had a written protocol for a randomized controlled trial, and I brought it to ENGOT. And at ENGOT, it was heavily criticized, and it was highly recommended to change it into a prospective observational study because 2016 was at that time, and there were really multiple, huge amount of data on patients who were treated by a standard approach, radical plus full pelvic lymphadenectomy. So, we were able to analyze these papers, say, yes, this is the reference recurrence rate for our patients. And of course, observational trial is always easier and faster to conduct.
Thank you. That's really interesting. So, ultrastaging, we saw from your presentation, ultrastaging is a key element of the methodology of this trial. And can you elaborate on how did you manage to perform a central pathology review at your institution?
Well, we should understand that we speak about lymph node staging, which is in principle diagnostic procedure. It has never been proved that lymph node staging would be therapeutical procedure. So we speak about it. The main aim is not to improve prognosis. The main aim is to identify high-risk group of patients who are lymph node positive and who will receive adjuvant treatment. That's the main purpose of lymph node staging, because if lymph node staging was therapeutical, then we should also remove positive lymph nodes that detected and we don't do that. And we know that after chemoradiotherapy, the local control of these tumors with positive lymph nodes is very good. So that's why we focus our attention in the study on this diagnostic part. And we said the most important for the study is ultrastaging, because this is the quality of the paper. And so that's why we also established a quality assurance program So the samples from each site
Right.
were submitted to the central lab in Prague and reviewed by our poor pathologist.
So the paraffin blocks.
Yes.
With the sentinel inside.
Yes. And I must admit that it played a crucial role in the quality of our study, because at the beginning we were receiving the paraffin blocks who were full of deviations out of the protocol. So we learned that the quality is now inadequate at that time, and we communicated it from the beginning of the study with the site. So I believe that we improved a lot during the study.
Of course, that's was really tough, I can imagine. So we understand that if intraoperatively N+, so positive nodes were found, it was abandoned radical procedure, and patients underwent chemoradiotherapy. Was this valid even for patients who had ITC, not intraoperatively, but at final histology? Did they receive adjuvant chemoradiation?
Actually, in the protocol, it was said that if metastasis is detected intraoperatively, patient is excluded from the study. So it was left in the hands of investigators whether they will continue or whether they will abandon further procedure. But you are right. You know, we had to decide what to do with ITCs, and we had a lot of discussion about it. And then finally, we decided that we will take any type of metastasis, any size of metastasis as N1, so as positive lymph nodes.
So they were radiated.
So yes. Well, you know, there are not that many patients.
Right, yeah.
Incidence of ITC is not that high, but yes, irrespective whether macro, micro, ITC, they were recommended adjuvant treatment.
Thank you. Talking about surgical approach, laparotomy versus minimally invasive, we saw from the results that there was no impact of surgical approach in survival. Do you want to comment this compared to the results of the LUC trial?
Well, yes. This is also in this respect, SENTIX is an interesting piece of information, because in our study, 1/3 of patients were managed by open, 2/3 by minimally invasive. It was interesting to see what the LUC trial did, because the LUC trial was published exactly in the middle of the enrollment. We discussed it with the steering committee, and it was decided to issue a warning letter. So we send a letter recommending open approach, not as a mandatory, but recommending an open approach. And we see that the proportion of patients managed by open surgery was for, let's say, half a year more frequent, and then it swung back. So, you know, it seems like people, went back to their historical behavior. And yes, finally it was 1/3, 2/3. And we really did not find any difference in the survival. Well, to comment on the difference with the LUC trial, of course, it was not powered. It was not aimed to detect. At the same time, it's an important piece of information. Here, my personal comment is that. You know, we cannot translate the LUC trial into that minimally invasive surgery is completely wrong. If this was correct, then we have to see, huge difference between open and minimally invasive arm. But in the LUC trial, it's statistically significant, but we speak about few additional recurrences in 300 patients. So it says that with minimally invasive surgery, there can be something wrong. In our sites, it was not the case. In our sites, because 60% of patients were operated by minimally invasive surgery, and they were okay. So in our study, minimally invasive surgery was not wrong.
Thank you. Thank you. Really nice point. So what was the reference prospective trial to compare the SENTIX, which is single arm, survival results? Because you said it is safe from the oncological point of view to do sentinel only, but how can we define safe?
Yeah, well, definitely. Well, this is the key topic, of course, for any observational trial, because the biggest benefit of the randomized trial is that you have a perfect control group. So the quality of the control group is the key. What we did in 2016, we really carefully reviewed available literature, which was massive.
27 studies.
Yes. So we reviewed data from more than 8,000 patients, and the majority of these studies showed the median recurrence reference rate at, and you must choose some certain points. Right. So it was at 2 years. Between 7 to 15%. And we said, okay, so let's set our reference recurrence rate very conservatively to 7%, to the very low bar at 2 years.
That's why you chose 2 years, because majority of the studies.
And at the end of the study, we have at 2 years we have recurrence rate 6.6%. So we are safely below this bar, and non-inferior margins, so we could of course go up, was 4%. So we would be good between 7 to 11%, and we were 6% in the recurrence rate.
And correct me if I'm wrong, but we know from another study, the SCAN study, that the peak of incidence of recurrence is about around 16-24 months, right? So you should detect the most of recurrences in a 2-year period.
Yes, but at the same time, of course, we have data from the whole follow-up. We stopped the follow-up after the 2 years after the last patient was enrolled. So we have 2 years follow-up as a minimum follow-up
for all of them.
But in patients who were enrolled at the beginning, they have 6 years follow-up. So we have the follow-up for the whole study. And I would say that another highlight in our study was that really we did we spent enormous time and energy for seeking the follow-up data from all our patients. So our study office was chasing the institutions all the time, and we really have a very complete follow-up, which is not that easy. I really am jealous to see that in some other trials, after 7-10 years, they claim that they have
all patients.
3% dropout rate. It does not correspond to our practice, because cervical cancer patients are young patients. They move, they change countries, sites, work, everything. So to keep them in the follow-up is a really big issue.
Thank you. That was really an interesting experience that you shared with us. So we are going now to the last question. SENTIX trial survival results represent important evidence for the use of sentinel lymph node only in the management of cervical cancer with tumors below 4 centimeters. Do you think that these results are sufficient to change our daily clinical practice?
Well, that's of course now the question. Whether the data from observational trial will be considered relevant enough to change the clinical practice, or whether people will say, well, there is ongoing SENTICO 3 trial, so let's wait for the outcome, and then if this is confirmed, then to change a clinical practice. This is something what I believe will have some evolution. There are already some regions or some institutions which perform sentinel lymph node only in these patients, so they are there even without SENTIX trial. I am, first of all, what I would like to say that finally, and I'm very glad for that, we did not compete to SENTICO-3 trial, because we started early. We finished about the same time when the SENTICO-3 was opened.
Right.
And now we present the data when the SENTICO-3 is about to be closed. So, you know, there was...
You don't interfere.
Yes, we will have, you know,
even
if we convinced everybody, there is no problem with the enrollment to the SENTICO-3 trial. Well, our SENTIX will not answer, you know, all the questions. So definitely SENTICO-3 will bring us a lot more data. For instance, morbidity, you know, for, you know, detailed comparison of the morbidity, you need to have a parallel group for the control of quality of life. But in my opinion, SENTIX trial really is relevant to change the clinical practice because of what I said. The purpose of lymph node staging is not curative, it's diagnostic. So we don't expect from the lymph node staging to improve the prognosis. We de-escalate, yes, we de-escalate, but at the same time, thanks to ultra-staging, we know that we detect 50% of metastasis more.
Right.
So it's more accurate in a diagnostic performance. We will more precisely detect patients with positive lymph nodes. And yes, we can discuss whether SENTIX is 92 points or 93.3, and in the LAC trial it's 92.7, but in open arm it's 90. Those are but there was no signal in the SENTIX.
No warnings.
That there will be, like, you know, imagine the situation in 2016. I remember that people were worried to join the SENTIX trial, to do only sentinel lymph node, and they expect, you know, we will see, you know, recurrences tomorrow because we don't remove all the lymph nodes, so we leave the lymph nodes behind, and there will be, but there was nothing happened.
Yeah,
and,
that was.
So there is no increase in pelvic side recurrences. There is no significant increase in local pelvic recurrences. Of course, there are some small differences of 1-2% between the recent trials, which were unavailable at 2016. But at the same time, if you look to the literature backwards, for instance, what has been published in the LAC trial, of 4.5 years recurrence rate in the open arm, 97%, 6 or 7 recurrences out of 300 cases has never been published. It's really super excellent. And I can only congratulate these sites, but we have 700 patients, and there is no obvious signal that there would be a risk of lymph node recurrences.
So thank you. I want to personally, and I think on behalf of ESGO and the Gynecological Oncology community, congratulate for your visionary project that is now come to an end 10 years after, and thank you for being with us. I really look forward to seeing this study published and to read it the full paper. Thank you.
Thank you, Nicolo.
Thank you.
Thank you.